Assalamu alaikum everyone and good afternoon. I would like to start this webinar by welcoming everyone welcoming everyone for the first sessions of the Poison Hour, which actually brought by ISAM. For those who doesn't know me, this is Afra Suwaidi, an emergency medicine consultant at SKMC and medical toxicologist graduated from Emory University, United States. I would like to start this webinar, of course, by just giving a brief about today's webinar. This is a toxicology-based webinar that will be held every month, usually of the last Thursday of every month. And the webinar will be led by a toxicologist based in United Arab Emirates, such as myself. We have also Dr. Lara, which I will introduce later on, and Dr. Sami Al-Ghannai. Before we start today's webinar, I would like to have a moment to sincerely thank Dr. Maryam Al-Naimi for her, support. For those, of course, I'm sure like everyone who are joining today knows Dr. Maryam Al-Naimi. She is the head of ISAM, and I would like to thank her for her extreme support for making this webinar today happening. Maryam Naimi was always approachable and very encouraging. And every time I go to her, asking her for something to do for the toxicology subgroup, she will be welcoming the idea. So thank you for your support. And would like you, Dr. Maryam, if you can give us like a short speech.
Allah يخليك دكتورة Afra. Thank you so much for this. And good afternoon, everyone. Well, it's actually an honor to see that the toxicology committee is officially up and running, and I'm honestly delighted that this is our first webinar, and inshallah we'll make it up and running with the coming few months. Dr. Afra, this initiative has been sincerely amazing, and everything that you guys are doing in the toxicology committee is, mashallah, perfect. So I would like to just say that this series, inshallah, will keep on running. And it's, as Dr. Afra has mentioned, that it's going to be every Thursday. And it would be a good opportunity for you to learn and share. And you can actually basically publish it around the region even. So it's going to be in the UAE and outside the UAE. Inshallah, it will be a very good toxicology platform where you can grow out of this topic. I also wanted to highlight that we shared in the e-newsletter that the toxicology committee is also open for members. So those who love toxicology and wants to learn more and maybe find an opportunity later on to meet with the toxicologist guru from around the country, so they can check their opportunities for going for fellowships and somewhere abroad. Inshallah, they will not, they will definitely help you and will not be hesitant to not do so. I am also looking forward to meet all of you, inshallah, in ASIM 25, which is upcoming in December. Inshallah, it will be held in Dubai. And I would love if I can see all of you. This is a huge opportunity for the UAE and basically the whole region. We also have in ISAM, I'd like to mention that we have a lot of committees. So do enter the website and check the other committees. We have POCUS, we have disaster and ECREM, and of course, toxicology, one of our biggest. I would encourage all of you to check what's your field and what are you looking forward to add up in your CV. So this is a very huge opportunity to learn from your seniors. I guess with that, Dr. Afra, thank you so much. I thank you sincerely for making this happen. And let's go ahead with the webinar.
Thank you so much, Dr. Maryam. Of course, to start our webinar, toxic triage, who is sick and who is sicker, I'm going to introduce one of our toxicologists in UAE, Dr. Lara Sulaiman. I'm sure most of you have met her or know her. Dr. Lara Sulaiman, she's an emergency medicine consultant at Rashid Hospital. She is also a core faculty at Mohammed bin Rashid University and adjunct faculty at Dubai Medical College. She is double certified board in emergency medicine, Arab board and European board. She is member of the Royal College of Emergency Physician from UK. She holds a diploma in medical toxicologist from Cardiff University. And she also holds a professional diploma in health leadership and innovation from Rochester Institution. Welcome, Dr. Lara.
Assalamu alaikum. Thank you, Dr. Afra, Dr. Mariam, Dr. Sami, everyone. Thank you for this great opportunity. And so without further ado, let's start. Can I share my screen?
Yes, you can share.
Okay. Okay. You can see my screen now?
From my side, not yet.
Okay.
Before, of course, Dr. Lara start, just would like you all to know that we are going to have an open discussion in the last like 15-20 minutes from the presentation. So please, I mean, I encourage each one of you to participate. Use the question and answer section where actually you can share your thought, your question. And for those who want actually to speak, if you have like a comment to add, if you want to speak, or I mean, add in the discussion, just raise your hand. I'm going to unmute you. Okay, Dr. Lara,
Okay,
now see your presentation.
Okay. So we can say that today we'll talk about how to approach and decide or triage your patients who come with the overdose or toxic exposure. Of course, we don't talk about the actual emergency triage, but we are talking more of a risk assessment when you start to see the patient. Sometimes you will have multiple patients, you might have a mass casualty, and those things need you to think which patient need to be seen first. So mainly we will apply a structured primary survey and early risk assessment for poisoned patients. We'll recognize common toxidromes and immediate red flags. We'll select evidence-informed we'll see the evidence-informed GI decontamination strategies, identify candidates for enhanced elimination, and know when to call nephrology or toxicology, and try to integrate the current guidelines highlighting into the bedside care. So first of all, I need you to remember these 3 cases that I will give you. And maybe before the end of the lecture, you can decide who you will see first. Then after that, after the end of the lecture, let's see if your decision will change. So the first case is a 22 years old female who was found unresponsive. Sorry, next to an empty amitriptyline pack. Heart rate is 132 with blood pressure of 84/50. Respiratory rate is 10. Saturation is 88 with temperature of 37. On the physical examination, a GCS is 6 with dilated pupils, dry mucous membranes, and she came initially with history of seizure. So this is the first patient. Then the second patient is a 45 years, just have a look at the ECG, try to write the findings on the side. The second patient is 45 years old male with 2 hours post-ingestion of around 60 tablets of sustained release verapamil for a suicidal ideation. And vital signs, heart rate is 68, blood pressure is 118/70, respiratory rate is 18, saturation 97%, temperature is 36.9. He's alert and not in distress. Again, just few seconds to have a look at the ECG. Then you will see this lady, she is 30 years with ingestion of 10 grams of paracetamol after an argument. She came 90 minutes post-ingestion. Heart rate is 92 with saturation of 100%, blood pressure 124/78, and 37 of the temperature. Vital signs stable, examination, no acute distress, and the ECG is normal. After that, you will have 7 years old male with 30 minutes post-ingestion of 4 to 5 metformin, 500 milligram tablets, non-sustained release. Heart rate 98, blood pressure 104/65, respiratory 20, saturation 99%, and temperature is 37. Mild nausea, not in distress, ECG is normal, VBG had normal glucose, bicarb of 24, and normal lactate. And then you will find a 29 years old female who's pregnant in her second trimester. Accidentally, she had double dose of her parenteral vitamins this morning. Normal vital signs, normal examination, and normal ECG. So these are the cases. Just now you can put on the side who want to see first, or at least where you put those patients. If you'll send this patient to the fast track, if you'll send the patient to monitored bed or to resuscitation area. Now, in emergency. So we have our priorities. Let's say that what will be our priorities in the first 5 minutes when we see those patients. So first, of course, we always will go, we say A, B, C. So your airway, breathing, circulations, maintain good oxygenation, establish an IV access, monitor, and don't forget the glucose check. Then you will treat the immediate reversible killers like hypoglycemia, severe opioid toxicity. If they are an active seizure, you need to address these conditions first. You will have a 12-lead ECG for all significant ingestions and unknown ingestions, because sometimes the ECG will give you an idea of what this patient can be ingested. Then you will go with a focus history, what happened, when happened, how much they took, and sometimes even you need to know why they took it, because we know that the patients who are seriously suicidal, they would hide some information because they don't want to be treated. And then, as appropriate or as needed, you can call your regional poison center, toxicology, as needed. Then we will go to the risk assessment, which is the main thing that we always focus when we assess those patients or when we handle patients with toxic exposure. Risk assessment is very important because you need to know ahead if you will need anything specific or any specific interventions that might not be available in your hospital, like a certain antidote that you need to call it from the poison center, like maybe the patient needed dialysis or ECMO that might not be available to your hospital, so you need to transfer that patient to a different hospital. So the risk assessment mainly will look at the exposure, the patient, and the agent. Exposure, so what the patient used, what's the dose, the formula, the route that it was ingested, and the timing. Formulation is very important because now we have a lot of sustained release formulation. Most of the medications, most of the antihypertensive, the anti-hyperglycemic medications, the cardiac medications are either in combination formation or in sustained release formation. And pay attention also to the dermal patches that some patients will take. Then you will look at the patient, so the patient age. The age, the comorbidities, the body mass, it's intentional or accidental. Because as we know, in pediatrics, we have the one pill can kill. Toxic exposures in pediatrics sometimes will be more dangerous than compared to adults. And the same way will apply for extremes of age. Patients with known cardiovascular disease, their hearts are already fragile, might not handle some of cardiotoxic medications compared when a normal, healthy patients. Then the agents, the kinetics of the agents, the protein binding, the volume of distribution, and the dialysability. When you know the agent and you know the pharmacokinetics and the pharmacodynamics of these agents, this will help you to decide when to send the drug level. Why we will send the paracetamol drug level always at least 4 hours post-ingestion. Why I will not depend on the first digoxin level unless it was taken 4 to 6 hours after ingestion. So these things related to the agent itself are important to decide what you will do next. We had a patient, we received once a call for a patient who had a high digoxin level in the CCU. And when we looked into, and the patient was completely asymptomatic, but the level was very high. When we looked into the patient's file, the level was collected 15 minutes after the patient received digoxin. So as the patient was asymptomatic, we said we'll observe the patient, we'll repeat the level after 4 to 6 hours. And actually, when we repeated the level after 4 hours, it started to go down. After 6 hours, it was back to normal. So the time of the understanding the metabolism of the drug will be very helpful when you decide what to do next. Then the context, again, self-harm. There is impose a high risk of patients hiding the history or giving you parts of the history because they don't want to be treated, and access to medication. So it's very important to ask what are the medications around the house are available, because maybe the patient will not take their medications. We had once a child who came with a beta blocker toxicity, and the source was actually her mother's medication. So when we know what's around, and the mother is the one who guessed, because she said, I only have beta blocker at home because of my anxiety. So these things are important to identify and do risk assessment for those patients. So then you need to look for the red flags. So what red flags are possible? Seizure is a red flag. Extremely low GCS, red flag. Unstable vital signs is a red flag. Altered mental status, hypotension, seizure, ventricular dysarrhythmias. ECG red flags like a white QRS, prolonged QTC. White QRS, there is a sodium channel blocker on the table that we need to handle. Shall we start with sodium bicarb? White prolonged QTC. Are we talking about the agents that affect the QTC, or there is an electrolyte imbalance that's affecting the QTC? Shall we start giving magnesium before having torsadopa? So all these things are red flags that you need to see it. And some key labs like basic metabolic panels, ABG or VBG, lactate level, the osmolar gap, the anion gap, drugs level when it's applicable and available, and glucose, of course. Now in the ED setting, usually it's really challenging for us in the ED setting because we have unreliable, incomplete history. Many of those patients are already agitated and violent, so it's very difficult to take history. And we had it last week. We had a serotonin syndrome patient. Very difficult to obtain any history of the patient. We had just a scattered history, and we depended really on his colleagues who went and they saw the CCTV cameras at the workplace, and they saw that he took something, and we matched it with the clinical symptoms to guess he went into serotonin syndrome. So these are very challenging for us in ED. The intent of self-harm, again, the diagnostic thresholds, patient came too early for the drug level to be accurate, or came too late to depend on the drug level to be accurate. Lack of competency in some patients, at least temporary, they cannot take a decision. The use of multiple substances altogether, so you'll have a patient with a mixed picture. The lack of support in treatment, maybe the patient we've recently noticed that many of the patients who are recently discharged with depression or psychiatric illness, few days later after the discharge, they will come with a suicidal attempt. So where did we go wrong? There is lack of treatment. Treatment was incomplete. Is it early discharge? There was no support at home. So these also can affect our decision in ED. And the legal concerns with certain substances. Many patients who will use illicit drugs, they will not tell you because they are scared of the police. So you will be just shooting in the dark depending on the clinical symptoms of those patients. Now, how you will approach such patients, approach to poison patients in general. So you do your risk assessment. You will decide the type or the need of decontamination. You will address your ABC. You will go for your specific therapy and the decisions of enhanced elimination. And sometimes in toxicological cases, your decontamination can be more priority than your ABCs, especially if you need to protect the physicians or the staff handling the patient. So you need to decontaminate the patient before treating them to avoid cross-contamination of the healthcare staff. Okay. There is a nice mnemonic that can help you a structured approach in the care of intoxicated patients in the emergency department, which is called the PIRATE mnemonic, which is basically the primary survey, the investigation identifications, the risk assessment, then the ADME when we talked about the substance itself, the therapy and evaluation. So primary survey, it's the same, your ABCDE. Very crucial and important when you handle patients with intoxication and the patient maybe can be obtunded or maybe you don't have clear history. Look into their pockets. You will be surprised what you will find. Then an investigation identification. So investigations like your ECG, your labs, your tox screen whenever applicable, and then the identifications of the clinical features and history of those patients. Many times we only depend on the clinical presentation. This fits sympathomimetic, this looks like sedative hypnotics, this looks like serotonin syndrome, and we treat them before knowing what actually was the substance that they took. Then the risk assessment, the agent type, the dose and the time, and the patient characteristic from age and comorbidity. And this also will help you to decide, will this be admitted? This patient, 6 hours observation will be enough. This patient needs a 24 hours observation. Sometimes we admit patients to ICU while their GCS is 15/15, initially stable, but we expect those patients to deteriorate and they need a one-to-one observation. And then your ADME. So your ADME, basically, what will be your aim in treatment? So you need, when you treat those patients, to reduce their absorption. By gastric lavage, I know gastric lavage is almost out. Still, they mention it, but it's almost out. Okay. By activated charcoal or any methods of decontamination, you need to reduce the distribution of the substance. By what? By using chelating agents or any antidote that will affect the distribution. Example, the Digifab. You need to alter the metabolism. By what? By other substances that will affect the metabolism of the drug, either to speed up the metabolism or maybe it will prevent the formation of toxic metabolite. Examples like the use of NAC in paracetamol or the famotidine in alcohol, in toxic alcohols. And then you need to enhance the elimination. Enhanced elimination like hemodialysis, hemofiltrations, plasmapheresis, multi-dose activated charcoal, all these methods will enhance the elimination. So again, our aim is reduce the absorption, reduce the distribution, alter the metabolism, and enhance the elimination. Then you go to your specific therapies, like specific antidotes, specific resuscitation therapy, and the evaluation. Evaluation where you will monitor, observe the patient, decide when to dispose the patient, where to dispose the patient, and remember, screen for child abuse, elder abuse, and psychiatric evaluation. Do not ignore the risk of suicidality on those patients. Now, so we finished our initial assessment of those patients. We finished the risk assessment. Now we have an idea. Then we will recognize the toxidromes. I'm sure on the next few months, we will have like specific lectures targeted to these toxidromes. But in general, we have the anticholinergic toxidrome, which will be with the antipsychotic, with the antiemetic, these drugs. Cholinergic toxidromes, which comes more with organophosphate and pesticides, opioids, sympathomimetics, and sedative hypnotics. And each toxidrome will have a cluster of symptoms. Remember, patients will not come with full-blown symptoms. You don't need to have all the symptoms to decide that this patient has this toxidrome, especially with mixed ingestion. With mixed ingestion, you will have mixed picture. So I love these diagrams. Always these illustrations will show you the different toxidromes, like the anticholinergic, when we say red like a beet, hot like a hare, dry like a bone, mad like a hatter, blind like a bat. Cholinergic toxidrome, where they are pouring everything out, so they are vomiting, salivating, having diarrhea. Then the opiate, they have bradypnea, bradycardia, low saturation, low GCS. You have other toxidromes like synthetic marijuana presentation, sympathomimetic, and the serotonin syndrome. Now for the antidote. Do we need to give antidote for all toxic exposures? No. Do all toxins have their antidote? No. But we need to decide when to give the antidote if needed. So naloxone, for example, in opioid cases, naloxone, you don't need to give naloxone for every opioid. Sometimes we give it just as a diagnostic to know if the patient will improve. Most probably they took an opioid. But our main aim when we give naloxone to opioid overdose patients is to keep them sedated enough to breathe on their own. You don't need them to wake up completely, especially if they're chronic opioid dependent, because you will just precipitate withdrawal and then you will have to sedate them again. So you need to keep them breathing on their own. The NAC for acetaminophen overdose, sodium bicarb usually for sodium channel blocker drugs, digoxin immune fab for digoxin toxicity, hydroxycobalamin for cyanide, atropine and pyridoxine for cholinergic toxidrome of crisis, fomepizole for toxic alcohol. And just always remember, we have a poison center where you can utilize the poison center to ask them about the availability of antidotes, and they can help you sometimes even to provide the antidote to your hospital. So always utilize the poison center just do not think like, okay, we don't have the antidote in the hospital, so we'll not have it available. Contact the poison center. They are very happy to help you to find the most suitable antidote for you and provide it for you. So now, back to our cases. Let's see if your decision in triaging those patients will change after hearing the lecture. So, for the first lady, what do you think? I don't know how can I see the comments on how
I
they
have
will
the
see the
question
patient.
and answer opened. And
Mhm.
I mean, for them, anyone who wants like to share their thoughts, please utilize it.
Yeah, so I need to hear like this patient, where you will take her.
Maybe Dr. Lara, you can just summarize the case.
Okay, so this is the first one who had the 22 years old female who was found unresponsive next to an empty bottle of amitriptyline. She had a history of seizure en route. She's tachycardic, hypotensive, and with a GCS of 6, dilated pupils, dry mucous membranes, and the ECG, just because it was, now it's a small size, she has a picture of terminal R waves and a white QRS complex.
So great, we have some answers here. We have goes to resuscitation, we have level 1 triage, then we have resus, TCA toxicity with seizure, which suggests severe toxicity, good. We have
Perfect.
resus again, and then we have she is unstable on a primary survey and ECG shows classic TCA with white QRS, would send her to the resus immediately. Good, priority 1. Okay, I like the answer.
Okay, so perfect. The first option, I don't know how to remove this again. So the first option was resus. You are all correct. Okay, for the second patient who we have is the one who have the 90 tablets of, the 60 tablets of sustained release verapamil, but still vitally stable, and they came alert and not in distress, and the ECG shows element of heart block. Where this patient will go?
So good, we have here an answer. Triage as patient 1. I like this answer. Okay,
Okay.
But at this point, patient to some extent consider stable. Okay, we
Stable,
have
yes, but
level 2
يعني
cardiac
we
monitor.
okay.
So how many hours? Would the hours differ, Dr. Lara, for the second patient? Like the
So
hours
if they come,
patient.
yes. So if they come, like let's say they came next day, I might not send them to the resus because they passed 24 hours. It says yes, it's a sustained release, but if after 24 hours they are still stable, asymptomatic, maybe I will not send them immediately to resus. But they come immediately, and I know that they already start to have some changes in the ECG. I will not fault anyone. No one will fault you for sending that patient to resus because they might deteriorate.
Exactly.
But
I agree with
yeah,
that because maybe they didn't reach the peak. They are
yes,
like stable at this moment, but God knows what will happen within 1 hour.
exactly. So, but for sure, they should be in a bed with a cardiac monitor, a close observation area, or a high dependency area, or how your ED setup, but not to a fast track or a non-monitored bed.
Good. So most of the
Perfect.
answers is monitored bed, call for help, oxygen, monitor, IV line. Excellent answers.
Okay. So
Okay, we
then,
have, I'm just gonna like comment on this. We have, although patient is stable at present, this is a high risk, considering sustained release tablet good, as it is still early. Chances are the patient will go into serious brady, will send the patient to resus and avoid losing them at any other area. Needs monitored and bed at least. You are right, completely right. Because you know, these patients, like with calcium channel blocker, beta blocker, they can deteriorate very fast when they deteriorate. Initially, they can present, if they like present you immediately, they can be very stable. But later on, they will deteriorate really fast.
Asima, you still remember your tox rotation. Perfect. Okay. Then we have our favorite, most common presentation, the paracetamol. It's 10 grams, asymptomatic. She came 90 minutes after ingesting her paracetamol. So I want to ask two questions in this. Where you will send this patient and when you will order the paracetamol level? Okay. So what are the answers for this lady?
Still, we are waiting for them to answer. Okay,
4 hours post-ingestion.
okay, so we have the 4 hours post-ingestion, drug level at 4 hours, good.
So in this patient, the decision to when to send the levels and these things also, and when to start the NAC also can, let's say it depends on your hospital. So first of all, 10 grams, it's usually not of a high risk ingestion, especially if we will see in relation to the weight of the patient, because 10 grams can be below 150 milligram per kg for certain people. And if they are really underweight, it can be more than 150 milligram per kg as a toxic dose. So we need to see how much it's in milligram per kg first. And if your center, you will know that you will have your paracetamol level within 8 hours of your ingestion, then you can wait for the level and not start her on the NAC. But if you know your hospital will not get the NAC level until beyond, the paracetamol level until beyond the 8 hours, you can either transfer to other facility that they can manage that patient, or you can start, if the significant ingestion, you can start the patient on NAC until you get the levels. Because the most important thing and the most important part is they receive the NAC to get the best chance of treatment and survival, to receive the NAC within 8 hours post-ingestion. So this is how it will go with this patient. Now, this patient, again, it's stable. She can be on a normal bed for observation until we get the levels, and we can decide if she can be discharged home, or if she need admission for NAC. Okay. Then we have the kids, our favorite creatures who always make us panic. So what do you think? This 7 years, it's not 7 months, it's 7 years male or boy who ingested 4 to 5 tablets of metformin. What do you think?
So we have here Sana, she's saying level 2. Keep the patient on level 2. Okay.
Okay.
Any other comment?
Okay. So if we want to break it down, so this child, he ingested metformin. Yes, metformin is usually a drug that can have fatal outcomes in certain toxicity and poisoning. And again, with kids, we'll go with 1 pill can kill. But it's 4 to 5 tablets, which is not of a significant ingestion. It's a non-sustained release, which is kind of something better than the sustained release. And the patient is asymptomatic and vitally stable with normal lactate, normal glucose, normal examination. So yes, we'll not send this patient home. We keep them for observation, but they don't need resus. They don't need a closed cardiac monitor bed. They can be seen in a normal bed. Okay?
So we have here an answer saying that, but it can lead to hypoglycemia. Can it
So
lead to hypoglycemia?
ideally, metformin does not cause hypoglycemia.
Yes, it doesn't.
Yeah. Yeah.
So,
But again, as we said, the child here, we mentioned the child has no hypoglycemia now. So we are not sending the child home. We will monitor them, but they don't need to be on resus. They can be in a normal bed. Okay. And then we have the pregnant woman who took 2 tablets accidentally of her pregnant vitamin supplements.
what is very important to check on in this vitamin supplement?
Iron.
Check the
Perfect.
answer, iron.
Yeah.
Always check for iron in multivitamins, always, especially in
Yeah.
children. especially in children, and especially in children those who actually ingest their mother tablet, maternal tablet, because usually these pregnancy tablet, they has high concentration of iron, not like even the usual one, because many multivitamins has no iron or has some extent of iron, but usually the one that actually prescribed for pregnant ladies usually has higher concentration of iron. And this was like a common where patient like in US, they used to come with overdose after ingesting their maternal iron tablet, not iron tablet, multivitamins tablet, but they will have like iron toxicity. Of course, this is like, I'm just talking about other things, not this case.
Yeah,
So
so if
yes, please,
Hello?
Doctor, proceed.
Yeah, so for this lady, she only took 2 tablets. She's vitally stable. She can be discharged. Iron, it's only 2 tablets. We can, after looking at the level of the concentration of the iron, but usually this is an insignificant ingestion, and it will not do any harm for her if she took these 2 tablets, especially if she's healthy, she has no risk factors, nothing, then she can be discharged with instructions طبعا to come to the hospital if she needs anything.
Okay, so here we have good reassurance, one of the answers, Mahmoud, and then we have also observation for iron toxicity. So if we are talking about this case, especially, why Dr. Lara will not observe?
Because she took only 2 tablets, so it's not a significant ingestion, not a significant toxicity. She did not take like the whole bottle, or she did not take like 3, 4, 5 extra tablets of her maternal vitamins. So the risk of iron toxicity is almost negligible or insignificant in this patient. And if she can go in with a proper reassurance, proper counseling for her, she can come if she has any red flags.
Yes. And other things, keep in mind that when you check the iron concentration, is always what you are counting is not the iron itself, the dose of iron. You are counting the element iron. So it depends on the formula, you will calculate the elemental iron. Basically, what caused the toxicity is the elemental iron. And it differ between each formula to others. But just like general, rule, we will start think about toxicity when there's 20 milligram of elemental iron per kg. This is where
Exactly.
would you think about toxicity is.
Yeah. Okay. So this is a summary of these cases. So if you can see the column of the red flags, we can see that there is a red flag in the first case, the second case, third case, we said potentially toxic with early presentation. The fourth and fifth, they are just low minimal symptoms. So this is what we say about risk assessment of those patients. So in conclusion, you can face these cases anytime, even if you have the smallest rural clinic in a mountain, you still can have toxic exposure. And your systemic approach is the key. And always utilize your hospital, region toxicological center, and poison control center when you need. Risk assessment is really crucial. It's very important. Many times, it even happened with me sometimes that I would underestimate the patient, or they come early, and then during the observation, it will deteriorate. And we need to really be on top of those patients sometimes as early as possible to prevent any complications. And not all poisoned patients will need hospital admission. Just one thing about the risk assessment, because it just happened last week, this serotonin toxicity patient. When I wrote the recommendation from our side as a toxicology team, we recommended that the patient to be admitted in the ICU. That patient was not yet intubated, and he was just having the agitation, the tachycardia, the sweating, and the clonus, but he was not yet intubated, and he did not have seizure yet. So because we have high dependency beds in our hospital, so we have ICU, and we have the high dependency, and we have the normal ones. So then the ICU doctor was asking, like, shall we do it? Do we really need a ICU bed? Our ICU beds are really precious if he's not intubated. And the medical was asking the same. And I told them, if you can provide really a closed monitor, high dependency, where they will really pay attention on this patient. Yes, because this patient might seize. And I'm expecting that this patient will require high doses of benzo. If they will not seize and require intubation, they will require high doses of benzo to control their agitation and their symptoms. And just literally 10 minutes, the patient sees in our recess. So we had to intubate, and then he ended in the ICU. So sometimes that's why your risk assessment, it might not make sense to someone else, but because you know that this patient will deteriorate, they need this monitor. Because this patient, if he goes to the ward, sometimes he might seize without someone knowing about him. Okay, so risk assessment is always important, and there is no harm to over triage the patient rather than untriaging them. Thank you.
Thank you, Dr. Lara. Thank you for such good presentation. I'm going to pause here. Please, for our attendees, please share your thoughts, your question. We have, quite enough time. We have almost like 15 minutes, and would like to discuss anything. So we have here anonymous attendees. Informative and comprehensive lectures. Please send us the future meeting links. Then we can share it with our GPs. Dr. Mus'ab Al-Ayoub, consultant of, Dr. Mus'ab. Welcome, Dr. Mus'ab. Sure. You can use actually the same link. We are going to have our upcoming webinars on the same link, and we'll keep sending it through eSIMs. So you can approach it through eSIM as well.
It will also be in the newsletter of the upcoming e-newsletter. So we will make sure that everyone gets it so we can distribute it around the country, inshallah.
Great. And actually, it is actually a recorded webinar. So I think, Mariam, also we can upload it on the website, right?
Absolutely, yes.
All of our webinar will be recorded. And just, Dr. Lara, if you want to add anything, please feel free.
Sorry, I lost the connection initially.
So I was wondering if you want to add anything, please feel free.
Again, that's it. We need to really emphasize on the importance of risk assessment and these things. Inshallah, for the future meetings, we hope we'll have more attendees. We'll have, inshallah, more discussions. I'm really happy if they have any questions, you are free to ask. You can reach me. I think many of them, they have, and many of you, they have my email and my mobile number. And always remember, please remember our poison center. Okay, we always get back to them. They are really helpful. We first some cases in between here and there, we were looking for specific antidotes. And even for private hospitals, if any one of you guys are working in a private hospital, please, the poison center is also available to help. And that's it, yeah.
So just thank you, Dr. Lara. Before we wrap up our sessions, for our next webinar, so the date will be, to be accurate, the date will be on the 25th of September. So the last Thursday of every month. And our next topic will be managing the hot patient, where how to manage hyperthermia in ED. It will be presented by me, inshallah. So please join us. And before I wrap up the session, I would also add that I have received so many emails from so many of you who are interested to join as a member in the toxicology subgroup. So, and I'm going to respond very soon to your email. But please keep in mind that the toxicology subgroup will be very active group, and there will be so much rules and so much commitment and so many things to do, this webinar is just part of our activities. We will have so many other activities that we'll be doing either virtually or in person. This is just to keep in mind that whoever wants to join, keep in mind that you will have to be committed to our group. And of course, for those who are still or interested in joining, please email me. I don't know if I can if I can put my email. It is Dr. Afra Suwaidi@gmail.com. And thank you, everyone. Thank you, Dr. Lara. Thank you, Dr. Mariam.
Thank you, everyone.
You're most welcome. Inshallah, we'll get to see you next month.
Inshallah.
Great.